Welcome to the PharmGen Ed Bridging the Gap Between Science and Practice Train the Trainer session for asthma. Today is Tuesday, November 2nd, 2010. This presentation is supported by a grant by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Today's agenda includes an overview of the PharmGen Ed program, review of the educational content in asthma, future webinar dates, contact information, survey instruments, and a question and answer session. All copyrighted content included within this presentation has been granted copyright permission. No part of this presentation can be reproduced in any form without permission of the rights holder. The overall objective of the Pharmacogenomics Education Program, Bridging the Gap Between Science and Practice, or PharmGen Ed, is an evidence-based pharmacogenomics education program designed for pharmacists and physicians, pharmacy and medical students, and other healthcare professionals. The overall objective of the PharmGen Ed program is to increase awareness about current knowledge of the validity and utility of pharmacogenomic tests and the potential implications of benefits and harms from the use of the tests. We have the following educational modules available as part of the shared curriculum for faculty. The webinar dates for these sessions have been provided and will be provided at the end of this presentation. In the following discussions of each therapeutic area and the pertinent pharmacogenomic tests, the information will be presented in the following format. The gene or the patient case, the gene and or allele of interest, functional effects of the gene and or allele, prevalence rates of the gene and or allele variant in different populations, the available genomic test, summary of the most significant clinical data available to date, and this information is further organized into literature that affect dosing or drug selection, those that affect efficacy, and toxicity. And finally, recommendation for genomic testing from reputable agencies or national guidelines, followed by a patient case summary. At this time, we would like to introduce the author for the Asthma Module. Dr. Alice Gardner is an Associate Professor of Pharmacology at Massachusetts College of Pharmacy and Health Sciences, Worcester, and Adjunct Professor at the Department of Biochemistry and Molecular Pharmacology at the University of Massachusetts, Worcester. Her scholarly interests include G-protein-coupled receptor signaling as it relates to bronchial smooth muscle signaling and neurotransmitter regulation. At this time, I would like to introduce Dr. Alice Gardner.
Hello, everyone. Thank you for attending the Asthma Module webinar. The learning objectives for this module, as you can see, are to identify specific drug therapies used in asthma in which pharmacogenomic testing can be applied in the clinical setting. I'll summarize the evidence-based recommendations as it relates to pharmacogenomic testing. And also, at the end, you should be able to use, where appropriate, patient case scenarios, formulate a plan for pharmacogenomics testing based upon available scientific evidence. The presentation outline for today's session is going to be from select pharmacogenomic effects in patients with asthma as it applies to specific genes or alleles and the pharmacotherapy associated or related to those alleles. Specifically, we'll look at the adrenergic beta-2 receptor gene, the ADRB2, and as it relates to beta-2 agonist pharmacotherapy. We'll then transition and look at two other genes, the corticotropin-releasing hormone receptor, also known as the CRHR1, and also the Fc fragment of the immunoglobulin E low affinity 2 receptor, the FCER2, and those will be associated with the pharmacotherapy of glucocorticoids. Lastly, we'll look at the arachidonic 5-lipoxygenase gene, also known as a LOX5, as it relates to leukotriene modifier therapies. Again, as previously discussed, our therapeutic areas for discussion, the format is following patient case, where appropriate. I'll also discuss or highlight the genes of interest, functional effects, population prevalence where noted, and also clinical relevance as it relates to dosing schedule, selection, efficacy, and toxicity, and if there are any genomic tests or testing recommendations as supplied in the guidelines, and also summarize the patient case summary where discussed. So I'd like to start off with this case. This was based on a case study in the literature, and it applies to a 49-year-old African-American female who presented to the emergency room with acute shortness of breath. Her history revealed that she had had multiple hospitalizations for her asthma. And upon discussion with the attending physician, she denied any non-adherence to her asthma medications. But she did report that she very frequently used her short-acting beta agonists. Upon physical examination, you can see that there are some signs that do indicate that she is in acute respiratory distress and she's having an asthma exacerbation. For example, she's tachycardic. Her respiratory rate has increased. It's up at 24. Typically, we should be seeing something around 14 to 18 breaths per minute for normal. Her oxygen saturation is low. And if you go into the reference I have given as it applies to Metzinger, you will see that she indeed had other pulmonary and respiratory lung function tests that supported that she was having a moderately severe asthma exacerbation. Her labs also show that she's hyperglycemic, she's hypocalcemic, and she's hypophosphatemic as well. She has a rather complex past medical history. Not only does she have asthma, but she has hypertension. She has had community-acquired pneumonia, obstructive sleep apnea, pulmonary emboli, and deep vein thrombosis. Her asthma meds are several-fold. She is on a short-acting beta agonist, albuterol. She is also taking a combination of fluticasone and salmeterol, a long-acting beta agonist with a corticosteroid. She's on a leukotriene modifier, montelukast, and she's also on levalbuterol, which is the R enantiomer of albuterol, as well as ipratropium. Her doses, as she presented at the ER, were unknown at the time. No known allergies. But I think the question we should be asking when we look at this patient case is why is the patient not responding to her beta agonist? She has 3 in her pharmacopoeia there. And we may also want to consider what polymorphisms might be impacting the use of her beta agonist. And finally, what might we recommend for future pharmacotherapy for this patient? So before we finalize the outcome of the case, I'd like to just give a brief overview on asthma. It's well established now that it is an inflammatory disease of the airway with episodic reversible bronchospasms. The pathophysiology is complex. It's certainly with inflammation at its center, where there has been a complex self-amplifying interaction among cells, cytokines, and neurogenic components in the airway, which actually result in chronic symptomatic inflammation, along with bronchial hyperresponsiveness and airway remodeling. And as shown in the cartoon on the left, you can see the outcome is that the diameter of the airway lumen is severely reduced, thus leading to airway resistance. And we can also understand, given the pathophysiology, the signs and symptoms that a patient might present with. For example, wheezing, coughing, bronchoconstriction, mucus hypersecretion, shortness of breath, and when severe, obviously intercostal retractions upon examination. Typically, our treatment of the asthmatic patients, there's three major categories. There are the bronchodilators, which can be used as rescue and also for prophylaxis. There are the anti-inflammatory agents and also the newer group of agents, the antibodies. So let's take a look at the first gene of interest, the ADRB2, which stands for the adrenergic receptor beta-2 subtype, and how it relates to beta-2 agonist pharmacotherapy. As mentioned before, the gene of concern is the ADRB2, and this gene is actually found on chromosome 5q31-33. And it actually, as I mentioned previously, it encodes for the beta-2 adrenergic receptor. Now, interestingly, this region has been linked to asthma and related phenotypes, including those who are bronchial hyperresponsive, who may have atopic asthma, as exemplified by increased serum IgE levels. And if we take a further look at the beta-2 adrenergic receptor, it belongs to the superfamily of G protein coupled receptors. Its signaling pathway is such that it has an associated GSG protein, whereupon activation will result in increased cyclic AMP and a PKA-mediated bronchodilation in the airway smooth muscle. When these receptors are stimulated, as shown from experimentation, it will result in a potent relaxation of the airway smooth muscles. So obviously in the pharmacotherapy, beta-2 agonists are a mainstay therapy, not only short-acting and long-acting forms, but also for their need as in rescue medication, as in the short-acting beta agonists, and the long-acting beta-2 agonists for prophylaxis. In the next cartoon actually shows the signaling pathways related to the ADRB2 gene. Not only do we see that there is a complex intracellular signaling pathway that leads to relaxation, but this receptor is also involved in multiple aspects of airway regulation, such as regulation of genes, there's channel regulation, and there's also a PKA signaling effect on proliferation of airway smooth muscles, mainly an inhibition of growth. And I would refer you to this reference by Billington, where he gives a very nice overview of more details of this signaling. So the beta-2 adrenergic receptor that's encoded by the ADRB2 gene is highly polymorphic. There's actually been a few most studied single nucleotide polymorphisms, or SNPs, in which I will refer to these as later, of this receptor. And the most studied to date have actually been threefold. There is the arginine at position 16, the ARG, which is the wild-type allele. The ARG-GLY16, again at the amino terminus of the beta-adrenergic receptor, which is the ARG-GLY, where the arginine has been mutated to a glycine. That's a heterozygote allele. The other polymorphism studied is the homozygote variant, where the two glycines are the alleles. The other SNP that's studied is the glutamine, which has been mutated to glutamic acid. That's found at position 27. And as described there, you can see the glutamine 27 is the wild type, the glutamic acid, the heterozygote, and the glutamic acid is the homozygote variant. And the third most commonly studied SNPs are the threonine that's been mutated to isoleucine at position 164. The threonine being the wild type allele, the threonine to isoleucine being the heterozygote, and isoleucine being the homozygote variant. Now, I do want to say before I go on to the functional effects of this, those are not the only SNPs that have actually been studied in the ADRB2 gene. There's actually been multiple SNPs identified, but really no clinical studies to date have been associated with these extended SNPs, simply because the clinical study would become unfeasible. So let's look at some of the functional effects that have been well studied in the ADRB2 gene. The first one was in that looks at the arginine 16 wild type versus the glycine variant. In vitro, there's two contrasting effects that have been associated with these allele changes. In the wild type, in vitro, when they are exposed, human airway smooth muscle cells are exposed to the beta-2 agonist isopreternal. With the wild type, there's actually a reduction in receptor expression upon agonist stimulation. There's actually about a 78% reduction, and functionally this translates into a decreased beta-2 agonist-induced downregulation or desensitization. In contrast, the glycine 16 polymorphism of this receptor is very susceptible to enhanced agonist-induced downregulation. You can see that there is actually a 96% reduction in receptor expression when exposed to isopreternal. And again, that functional effect translates into enhanced agonist-induced downregulation and desensitization. Other studies that have looked really in vitro at the effect of the other alleles that I discussed, mostly the wild type glutamine at position 27 versus the variant, again, that has an in vitro effect on altering receptor expression. The wild type actually has a 78% reduction in receptor expression. Contrasting that with the variant, you see that it is that has only a 29% reduction in receptor expression with agonist stimulation, being minimally affected, and that translates functionally into minimal beta-2 adrenergic agonist-induced downregulation or desensitization, compared to the wild type, where we see a decrease again in beta-2 agonist-induced regulation and desensitization. The third most commonly studied SNP, which was the threonine at position 164, we have a different in vitro effect. In the wild type, we actually see enhanced binding affinity of the beta-2 adrenergic agonist and enhanced GS coupling and activation of the signaling enzyme adenylate cyclase. And functionally, we actually see that as enhanced beta agonist binding, which makes sense, can trigger the cellular signaling pathway. The other variation that's being studied is the threonine to isoleucine 164 variant. To date, there's been no isoleucine polymorphisms actually discovered. But in any effect, this heterozygote variant has decreased binding affinity of the agonist and actually a reduced intracellular signaling in human airway smooth muscle cells. If we were to look at this functionally, we would see that there's actually a decrease in beta-2 agonist binding. And in some studies, it's actually translated to decreased duration of action of salmeterol. Looking at the population prevalence of the ADRB2 gene, you can see that the numbers are quite variable, amongst the various SNPs and also across the different ethnic groups. I'm not going to read those at this point, but I have summarized the most meaningful points in the next slide on population prevalence. Differences do exist in the allelic frequencies among the various ethnic groups, and specifically the allelic frequencies for ARG16 gly and glutamine 27 glutamic acid are significantly different amongst the various ethnic groups. The ARG16 wild type has an increased occurrence in African Americans and Asian populations. And therefore, for this fact, in vivo and clinical studies have actually focused on this polymorphism more so than the others. The threonine isoleucine 164 heterozygote polymorphism actually has a low frequency amongst ethnic groups. And the variant, the homozygote variant, isoleucine 164, has not been found in an individual to date. And so we don't have any clinical significance associated with this to date. So looking at the literature to see if there's been any dosing or selection changes that have been recommended based on these polymorphisms, there has been none. And to date, there is actually been no literature related to the ADRB2 SNPs and beta-2 agonist side effects. Although I have to say that some studies do suggest a decline in the bronchodilator response with some short-acting beta agonists and some of the polymorphisms. But overall, if we were to look at an assessment of the numerous pharmacogenetic studies that looked at the response not only of short-acting beta agonists and long-acting beta agonists, a real consensus on the effects of the ADRB2 variants has not been reached when it comes to toxicity. But there has been a few studies, which I'll focus on later, where there does appear to be some reproducible adverse effects in subjects who regularly are treated with short-acting beta agonists. So let's take a look at some of the studies that have shown some clinical relevance with reference to efficacy or response. Again, this is a study that was undertaken by Taylor in 2000 that looked at either the wild type, the ARG-16, or the glycine 16 variant. This was a randomized, double-blind, placebo-controlled, three-way crossover study of 157 patients who were diagnosed with mild to moderate asthma. The primary endpoints in this study were actually asthma exacerbations, both major and minor, and the criteria were well defined in the study, and I would refer you to that if you want some further information. And also a primary endpoint was the peak expiratory flow rate in the morning. The overall conclusions of this study showed that the ARG-16 had an increased frequency of major and total asthma exacerbations during albuterol compared to placebo. Yet the ARG-glycine heterozygote or the gly-16 variant didn't demonstrate any significant differences between genotypes when measuring the AM peak expiratory flow rate compared to placebo. The study also looked at the long-acting beta agonist salmeterol and the effect of the polymorphisms on outcomes with this long-acting beta agonist. But there was actually no significant increase in asthma exacerbations for any position 16 subgroup who took long-acting beta agonist treatment. And next study, there was a follow-up study done by Israel in 2000. And this is a retrospective study that looked at 190 adult patients with mild asthma as defined by a forced expiratory volume in 1 second greater or equal to 70% as predicted. These were patients who were in a previously randomized double-blind multi-center study carried out by Drazen in 1996, who had shown that, who looked at regularly scheduled as needed use of albuterol in asthmatics, and his outcome was that there was no deleterious or beneficial effects from regular use of asthma. But in that 1996 study, some patients did experience deterioration in peak expiratory flow rate during the study. So therefore, Israel followed up with his retrospective study in 2000 to look at these SNPs in these patients. And what he did find was that the wild-type patients with regular albuterol use had a greater decline in their morning peak expiratory flow rate. As you can see, it was significant from the value. I'll just go to the next slide to explore that visual in a little more detail. You can see that in the 2000 study, the patients, they were first treated with albuterol during the 16-week run-in period. And if you look at the different SNPs, you can see that there was a small decline in the morning peak expiratory flow rate in patients who were taking regular albuterol and who had the ARG-16 polymorphism. Now, the authors clarified regular use as 2 puffs 4 times a day of albuterol. And you can see that the group with the same polymorphism who used albuterol as needed did not have a decline. During the run-out period, in which the patients were returned to short-acting beta agonists, i.e. albuterol, on an as-needed basis, those who had previously used the agonist on a regular basis had a sharp decline in their morning PEF rate. Compare that to the arginine patients who had previously used it on an as-needed basis. They actually had an improvement in their morning PEF value. And as I said, the numbers, this was a significant difference between those two groups. There was no change seen with the glycine regular treatment with beta-2 agonists. So I'll return to the previous slide because I want to carry on with the Israel studies. He's studied these polymorphisms quite extensively. The next trial that he undertook was the BARGE trial. That was, again, a randomized placebo-controlled crossover in 7 to 8 adults with mild asthma. And the primary endpoint, again, was peak expiratory flow rate in the morning. And again, the outcome was that the ARGE 16 patients had a decreased peak expiratory flow rate in the morning when using albuterol. And that the ARGE, this phenotype, I should say, negatively affects albuterol use. In contrast, the GLI, the variant patients, had an increased morning peak expiratory flow rate. The next study that I'd like to discuss is the 2009 study by Weschler. This, again, was quite a large study population. It was 173 adult patients with moderate asthma. It was randomized, double-blind, placebo-controlled. And again, their asthma was, for moderate asthma categorization, they had to have an FEV50 or greater or equal to 40% as predicted, or 50% if they were using or had been using regular inhaled corticosteroids. And this study was really to determine the response of long-acting beta agonists, salmeterol, plus inhaled corticosteroids, and to see if there was any genotype specificity in these patients. And the inhaled corticosteroids that the patients were on was actually beclomethasone. If we were to look at the final conclusions, then the ARGE, the wild type versus the variant patients who had a combination treatment of salmeterol and inhaled corticosteroid, there was an improved peak expiratory flow rate in the morning compared to inhaled corticosteroids alone. And the increase in their lung function was not significant between genotypes, as we can see in more detail in this next slide. If we focus on A, and we look at the differences between the patients who had the wild type here versus the variant, when we contrast placebo versus treatment, as shown in the pink, you can see that between both groups there was no significance between the two different polymorphisms, but within the polymorphisms there was an improvement from the placebo versus treatment. However, there was one interesting aspect that was uncovered in this study. The authors actually carried out a post hoc sub-analysis of the African American ethnic group. That actually comprised about 20% of the cohort. And they found that those who had the ARG genotype, i.e. the wild type, didn't benefit when a long-acting beta agonist was added to an inhaled corticosteroid therapy, but the glycine-glycine variant genotype did. Now, I have to add a word of caution here that the authors concluded that the findings should be considered exploratory because it was only a small number of patients. However, they did say that there would have to be further studies undertaken in this ethnic group to see if indeed they do not benefit from the addition of long-acting beta agonists to inhaled corticosteroids. And if this does turn out, then it may be that it may decrease compliance with pharmacotherapy amongst this ethnic group. So regarding clinical relevancy and toxicity, summarizing it, the regular use of short-acting beta agonists have appeared to show some adverse treatment effects in ARG-16 homozygotes when used regularly. In the large trial, it was shown that lung function is not significantly different between the ARG-16 polymorphisms and the GLY-16 homozygote variants when long-acting beta agonists are added to inhaled corticosteroid therapy. And as a sub-conclusion, African Americans may not benefit from the addition of these long-acting beta agonists to inhaled corticosteroid therapy. So far, there has been a few cases where there has been some beta adrenergic receptor genotyping that has shown that the ARG-16 wild type does confer risk for asthma exacerbations, but currently there is not an FDA-approved test. And to date, there is no recommendations in the asthma guidelines for use. We'll just have to wait and see what comes out with the next updated education guidelines. There is, however, a predictive test currently under development for testing. So let's return to our case. Based on what we've discussed regarding the different types of SNPs associated with the beta-2 adrenergic receptor, we may begin to understand why this patient did have trouble with her asthma pharmacotherapy as it relates to the beta agonist. What happened was because of her patient's history and her self-reported adherence and her ethnicity, she was actually tested for the beta adrenergic receptor genotype, and it indicated that she was an ARG-16 carrier. And based on the Naranjo probability scale, this revealed that there was probable causality between her uncontrolled asthma in this patient and her short-acting beta agonist use. Her recommendations for therapy following this discovery was her beta-2 agonists were discontinued, and instead she was given muscarinic antagonists, tiotropium for maintenance therapy, and ipratropium as her primary rescue therapy. Outcome, the patient has been followed in the pulmonary clinics, and to date she's not been admitted to hospital for any further asthma-related events. So it seems somewhat contradictory. why should a person with the RGARG genotype result in adverse effects with regular use of short-acting beta agonists? If you cast your mind back to the previous slides, in vitro, this genotype was actually relatively resistant to downregulation and desensitization. But if we look in the literature, it seems contradictory. There's some in vivo results that suggest that these carriers have an increased bronchodilatory response upon first exposure to these drugs. But subsequently, upon extended exposure, the drug produces greater downregulation. So what's actually happening? Well, there's been several models that have been proposed to try and resolve this contradictory effect. There was one by Small who seemed to discuss this seeming discrepancy as follows. In vivo, endogenous epinephrine, which is a natural ligand for this receptor, actually causes greater downregulation and desensitization of the glycine-glycine variant genotype. When this individual is exposed to pharmacological doses of the beta-2 agonist, the effect is that the initial drug response and tolerance to this class of drugs is blunted in the variant phenotype. In contrast, when the wild-type RGARG phenotype is exposed to endogenous levels of epinephrine, downregulation and desensitization are less. But when the individual is exposed to pharmacological doses of the beta-2 agonist, the initial response to the drug will be greater, therefore greater downregulation, and therefore tolerance developing faster, and hence the adverse effects associated with this genotype. Okay. I think they will carry on and look at the next gene, which is the CRHR1 gene, as it applies to pharmacotherapy associated with inhaled corticosteroids. The inhaled corticosteroids are a mainstay of asthma therapy. And their mechanism of action is via binding of the ligand to the glucocorticoid receptor. The glucocorticoid receptor ligand forms a dimer, which then functions as a transcription factor via either activating or repressing gene transcription. It's been noted that glucocorticoids can inhibit pro-inflammatory gene expression, or they can actually stimulate anti-inflammatory gene expression. The result being they have ultimately potent anti-inflammatory effects. And this is well categorized in the literature, in which inhaled corticosteroid pharmacotherapy does decrease airway inflammation. In fact, they're one of the most potent groups to do so, as well as airway hyperresponsiveness. However, in the literature, it's also been shown that there is resistance to inhaled corticosteroids amongst asthmatics. There was a study by Malmstrom that showed that there was an actual 22% decrement in efficacy when prescribed these classes of drugs. So let's take a look at one of the genes associated with glucocorticoid therapy. We're going to first take a look at the corticotropin-releasing hormone receptor. The gene symbol is CRHR1, and this can be found in chromosome 17q, 2122, and it actually encodes for the corticotropin hormone receptor. Again, this is a receptor that belongs to the superfamily of G protein coupled receptors, And again, it has an associated G protein coupled to it, which will modulate its intracellular signaling. And in the hypothalamic pituitary axis, the cortico-releasing hormone receptor is associated with a G-alpha-S coupled activation of adenylyl cyclase by corticotropin-releasing factor. This results in increased cyclic AMP. There's a subsequent PKA-mediated release of adrenocorticotropic hormone. And in the periphery, adrenocorticotropic hormone will result in the peripheral release of our glucocorticoids, namely cortisol. Therefore, we can see that the protein product of this gene is actually a major regulator of glucocorticoid synthesis in the periphery. Functionally, when we look at the response of asthmatic patients who have been given inhaled corticosteroids, we can see there is a heterogeneity in the response. And there has been several studies that have tried to look and explain this response. There has been 3 diverse clinical trial populations that have actually been studied to look or identify SNPs that are associated with the CHR1 gene. And these clinical trial populations were the adult study, the Childhood Asthma Management Program, and the Asthma Clinical Research Network. And they, as I said, were evaluated to determine whether the genetics in this gene contributed to the variability in response to inhaled corticosteroids amongst asthmatics. And these were carried out by Tanzasera in 2004. They actually identified variants in the gene using a haplotype tag approach to identify the SNPs. And they found one important haplotype tag SNP, which is shown here, an RS242941. And within this, there's actually the wild type, as exemplified by GG. There is the heterozygote variant, which is shown by a guanine that has been changed to thymidine. And then there's the homozygous variant, which carries 2 thymidines. Another haplotype tagged SNP that was identified with this gene was the RS1876828. And again, for purposes of illustration, the wild type genotype has 2 guanines. The heterozygote carrier has an adenine guanine, and the homozygous has 2 adenines. They also identified based on their studies, a specific haplotype, which were also associated with changes in lung function when given inhaled corticosteroid pharmacotherapy. And we'll discuss this later in the upcoming slides. But first, I'd like to go over the dosing selection. Again, as with the beta-2 adrenergic receptor gene, there's been no literature related to these polymorphisms in the CHR1 gene that impacts inhaled corticosteroid dose or even the selection. Regarding the efficacy response, again, which we will discuss in more detail in the upcoming slides, the specific variants in the gene have actually demonstrated an enhanced lung function when inhaled corticosteroids have been given for short term. Contrasting that, there has actually been decreased lung function associated with these polymorphisms during long-term inhaled corticosteroid treatment. To date, no toxicity has been associated with the CRH1R polymorphisms and side effects. So let's look at the study that was carried out by Tantasera in 2004. As I said, he evaluated 3 independent trials or studies of mild to moderate asthmatics who were on a variety of inhaled corticosteroids. In the adult study, he looked at 470 patients who were taking flunisolide. In the Childhood Asthma Management Program, or CAMP, the participants were taking budesonide. And in the Asthma Clinical Research Network trial, they were using triamcinolone. And they looked at the usage of inhaled corticosteroids on a short-term basis. In the adult study in the CAMP, they looked at 8 weeks, and in the Asthma Clinical Research Network, or the ACRN, they looked at the effect for 6 weeks. The primary endpoint was a change in FEV1 from baseline. The conclusion of the study was that there were specific genetic variants in the CRHR1 gene that actually demonstrated enhanced lung function to short-term inhaled corticosteroid use in childhood and adult asthmatics. And the p-values between these 2 studies range from, as you can see, 0.06 to 0.025. And overall, the conclusion was that these variants were more likely to positively respond to inhaled corticosteroid therapy in the short term. A further study looked at the mild to moderate asthmatics in the Childhood Asthmatic Management Program, the CAMP study, and specifically wanted to look at the long-term effects of inhaled corticosteroids. This time, their primary endpoints were delineated. They not only looked at the change in FEV1 from baseline, but they actually looked at the number of asthma exacerbations. And they found that the CRHR1 allele variant, specifically the one associated with the RS242941 SNP, actually conferred an increased risk of poor lung function during long-term inhaled corticosteroid treatment. These were patients, by the way, who were randomized to a 4-year course of inhaled corticosteroids. These patients who carried the variants had a lower bronchodilator response to albuterol as well during their inhaled corticosteroid therapy. And concluding is that there are poor long-term responses to the corticosteroids are genetically and phenotypically distinct when actually outcomes are defined, such as poor lung function and so forth. Has there been any tests to date? Currently, there is no FDA-approved tests, and there has been no changes in the current asthma guidelines for routine use of corticosteroids in these patients who carry the variants. I'd also like to spend a few minutes and talk about the gene for the SCER2, which is the Fc fragment of the immunoglobulin E low affinity 2 receptor, and as it translates to inhaled corticosteroid therapy. As I mentioned previously, this gene does indeed is for the Fc fragment of the low affinity immunoglobulin E receptor, and this is an interesting receptor in that it's an important regulator in the biological actions of IgE in asthma. It's been shown to actually have a positive and a negative regulatory effect on IgE synthesis in asthmatics. And when the receptor is activated, it actually results in downregulation of the IgE-mediated immune response. We're all aware that IgE is important because it has been shown that it's linked to increased rates of asthma exacerbation, hospitalizations, and emergency visits. So a study by Tantasara, this is in 2007, he actually studied about 10 SNPs in this gene to see if, first of all, did they change levels of IgE in these patients, and did it affect differential expression of this receptor in a pediatric population. The one important variant that was identified was the SCER2-2206 thymidine. That was the wild-type genotype. In patients, it can also be mutated to a cytosine, and that's the homozygous variant. And there are also carriers of the heterozygous form, where they carry both a cytosine and a thymidine allele. An interesting aspect of this is that in the population, the allelic frequency for the mutant allele variant is quite distinct. In Caucasians, about 26% of the population carry this variant allele, and in African Americans, a much larger number actually have this variant allele. And we'll look at this in more detail in the subsequent slides. But again, based on the current literature, there has been no changes related to inhaled corticosteroid therapy as it relates to polymorphisms in this gene. Although, as an overall remark, we can say that if there is a presence of this polymorphism, there is an increased risk for severe asthma exacerbations and poor lung function while being treated with the inhaled corticosteroids. And we'll look at that in the next slide. As regarding toxicity, again, no literature related to the polymorphism impacting inhaled corticosteroid side effects. Okay. So here was the study that looked specifically at the wild type versus the variant polymorphisms in the immunoglobulin IgE low affinity receptor. It was a randomized, double-blind, longitudinal, placebo-controlled study in, as I said, children. These were from the CAMP study, who had mild to moderate asthma. The primary endpoint was to look at severe asthma exacerbations. They qualify that as either a visit to the ER or hospitalization during a 4-year period. And they also had another primary endpoint of looking at lung function decline over the period. They also had a secondary endpoint to look at IgE levels. The patients who were actually homozygous for the 2206C variant allele actually had significantly greater risk for severe asthma exacerbations while on inhaled corticosteroids. And importantly, this variant allele contributed to both recurrent exacerbations and poor lung function. And the presence of this variant allele also conferred higher levels of IgE and also differential expression of the low affinity receptor. And I would, if you would like to see some visuals of this, I would refer you to the study by Tantasura, who has some very nice graphs actually showing this effect in both the pediatric populations that were studied. Again, genomic testing, there's no FDA-approved test yet to identify these polymorphisms associated with the FCER2 gene, and no testing recommendations to date in the asthma guidelines. We'll next move on and look at the ALOX5 gene, the arachidonic 5-lipoxygenase gene, as it refers to leukotriene modifier therapy. By way of a brief introduction, as I mentioned, the ALOX5 is the gene that encodes for 5-lipoxygenase, which is involved, I am sorry, I skipped a slide there. Let me go back. Okay, here we go. Before I discuss specifically the ALOX5 gene, I'd like to just give a brief overview on the leukotriene pathway. It's well known that there are multiple genes involved in leukotriene signaling. And studies have actually pointed out that patients who take leukotriene modifiers, whether they be leukotriene receptor antagonists or lipoxygenase inhibitors, there's actually a variable response to this therapy. In the literature, which is quite extensive, there's multiple polymorphisms associated or related to the leukotriene pathway genes. And I mentioned a few here. There's the ALOX5, which actually encodes for the 5-lipoxygenase gene, which is involved in synthesizing the leukotrienes. There's the LTA4H, which is an hydrolase enzyme which converts LTA4 to LTB4 leukotriene. There's the LTC4S, which is a synthase enzyme which is involved in the biosynthesis specifically of LTA4 to LTC4. There is the MRP gene in the leukotriene pathway. That's actually a multi-drug resistant protein that transports leukotriene, LTC4 specifically, into the extracellular space. And then there are the two genes that encode for the leukotriene receptors, the cis-LTR2 and the cis-LTR1. And to date, most work has been studied on the cis-LTR1. It's a receptor that mediates the action of LTC4, LTCD4, and E4, and therefore the symptoms of asthma caused by these leukotrienes. As I said, there's heterogeneity in response to the treatment with these modifiers, and it could be the result of genetic variations in one or more than one of these genes. But we are going to, for the purposes of this discussion, focus on the ALOX5. The ALOX5 gene, as I mentioned previously, encodes for the 5-lipoxygenase enzyme, which is involved in leukotriene synthesis. And there's been several studies that have shown that if the variants of this gene are present, there is variability in lung function, as exemplified by our forced expiratory volume when patients are treated with the leukotriene modifiers. Specifically, one of the areas that has been studied in the ALOX5 gene is the transcription factor binding motif. that's actually found in the promoter region of the ALOX5 gene and is therefore important in encoding the gene and therefore ultimately affecting leukotriene synthesis. The first studies looked at mutations in the tandem repeats of the promoter region, specifically the SP1 binding motif as shown here, and that actually binds the transcription factors. And we're going to discuss the mutations in the SP1 binding motif in some of the subsequent studies, as well as other mutations in this ALOX5 gene. The population prevalence of the transcription factor binding motif mutations, typically if you carry the wild type, which is about 60.2% of the population, you carry about 5 of these repeats. If you're a heterozygote allele carrier, which is about almost 34% of the population, you may carry 3, 4, or 6 of these repeats. But if you are a carrier of the variant allele, there will be no binding motifs in your gene protein product of the gene. So let's look at some of the studies. A couple of studies that specifically looked at the effects of the mutations in the binding motifs of the ALOX5 promoter. They were carried out by Drazen and also by Teleria. And in the first by Drazen in 1999, it was one of the first studies. It was a randomized double-blind control in adults who had mild to moderate asthma. They were actually treated with an investigational 5-lipoxygenase inhibitor. They found that when the population who carried the variant, i.e. those that did not have any of the promoter binding motifs, they demonstrated quite a significant decreased response to the leukotriene modifier, i.e. this investigational 5-lipoxygenase inhibitor. Unfortunately, the study couldn't be continued because the investigational drug was withdrawn because it did not show an advantage on liver enzymes as compared to a current one that was on the market at the time, Xeluton. But that did show that maybe there was something with this ALOX5 promoter. So Teleria carried out additional independent studies on the ALOX5 polymorphisms, and he looked again in moderately persistent asthmatics who were treated with the receptor antagonist montelukast. In that group of patients who had the wild-type alleles, they had an improved lung function as shown by an improved FEV1. They had fewer asthma exacerbations compared to the ALOX5 variant genotype. So overall, the conclusion was that polymorphisms in this promoter region of the ALOX5 were associated with changes in FEV1 and asthma exacerbations. Further studies were carried out later as investigators began to look at further polymorphisms that were associated with the ALOX5 gene in conjunction with other genes that were associated with the leukotriene pathway. And this particular study was one looking at poorly controlled mild to moderate adult asthmatics who were treated again with the leukotriene receptor antagonist montelukast, but they also had theophylline as an add-on. A primary endpoint, again, was change in lung function via FEV1 from baseline and the number of asthma exacerbations. What they did see, and this time, was that heterozygote variant carriers, they specifically looked at another polymorphism associated with the ALOX5 gene, and they found that those that were heterozygote had a 73% reduced risk for asthma exacerbations versus the wild type, who had a higher risk. Now, I want to point out that this polymorphism is different from the polymorphism that was found in the promoter region, again suggesting that there are other areas that are associated with the effects of leukotriene modifiers. They also found that just as an aside, the MRP1 gene, remember, which is responsible for taking leukotrienes into the extracellular space, the heterozygote variant carriers had a 76% reduced risk for asthma exacerbations compared to the variants. And all I want to say, obviously, these results are not consistent with the Drazen studies. Again, I want to say that we're looking at two different effects associated with the ALOX5 gene, but I think what it tells you is it underscores the need for additional pharmacogenetic studies that target the ALOX5 gene. Okay, to the next slide. Okay. Okay. Carrying on with some other studies. This was again another more updated trial in 2007 by Klotzmann, who looked at adolescents and adults with a history of persistent asthma who had been treated with the leukotriene receptor antagonist montelukast. Again, they were looking at lung function, specifically FEV1 tests, and peak expiratory morning flow rate. Again, the responses in this, they looked actually at several genes in the leukotriene pathway, about 10 in all, but the identified responses to two specific genes and polymorphisms associated with the ALOX5 gene, and this time the leukotriene receptor cis-LTR2. They found that there was the changes in lung function tests associated with the ALOX5 and the leukotriene receptor polymorphisms were significant, and that the ALOX5 polymorphisms, single nucleotide polymorphisms, from non-promoter regions of the ALOX5 gene, and the leukotriene type 2 receptor, those who carry the variant alleles had a higher morning peak expiratory flow rate response. And their conclusions from this test was that there's a small subset of the population who carry these specific ALOX5 and leukotriene type 2 receptor polymorphisms. They're conferred a distinct phenotype when they respond positively to leukotriene modifiers. And the last study of significance associated with the ALOX5 gene was undertaken recently, and this again was in childhood asthmatics who had mild or moderate to severe asthma. Their primary outcome was to look at leukotriene secretion and also severity of the asthma. Again, the ALOX5 allele change that we're looking at was associated with the promoter region of the ALOX5 gene. And it seemed that the carriers, the variant genotype carriers of this mutation were more likely to have moderate to severe asthma. and they concluded that the ALOX5 genotype predicts asthma severity. Excuse me. Okay. So summarizing, it's quite obvious from the various trials that there is quite a large heterogeneity in the retreatment response to leukotriene modifiers. And this may be the result of a combination of polymorphisms in the key genes that are regulating leukotriene synthesis. But further studies obviously need to be carried out with these genes. Again, no testing for the ALOX5 polymorphisms. And again, there has been no recommendations in the asthma guidelines. At this point, I would like to acknowledge the reviewers and the editorial staff of PharmGen Ed. The primary reviewer and editor I'd like to thank very much is Dr. Joseph Ma, and also the associate editors and reviewers, Drs. Grace Koo, Lee, and McBain, and also the assistant editors, Caroline Hawley and Ashley Toole. At the end of this presentation, you will see there's a number of references which I encourage you to use as resources, and there are several. I'll just go through each of them. And that is the end of the presentation.
Thank you, Dr. Gardner. I just want to finish today's webinar with a few more slides, and then we'll open it up to a Q&A session. So we hope this information is helpful as you translate pharmacogenomic evidence into practice. If you do have any questions or comments, please email us at pharmacogenomics@ucsd.edu. We acknowledge the funding agency, CDC, the PharmGen faculty and staff at UCSD, consultants and reviewers for making these slides available. And we're actually happy to announce that this is our last webinar date that we have conducted. We've had actually quite several of them, and so for this year, I should say, and we've had several of them, as you can see here, in the dates and times. So we again thank those that have attended and those that have participated. Faculty who will be implementing prior or all of the PharmGen Ed curriculum at their own schools or colleges of pharmacy during the 2010-2011 academic year will have access to the educational materials. Faculty who currently do not have access should return a faculty agreement letter and indicate the specific modules requested. The program implementation will be evaluated using several survey tools. Faculty trainers will be asked to complete a post-training survey, and all survey materials will be mailed after completion of all webinars in November. So we're now ready to begin the Q&A session. At this time, I'm now going to unmute the audience, and then we ask that those that have questions, you can either use the chat function or to just state it verbally, and we'll go from here. So at this time, we will unmute the audience.
The conference has been unmuted.
So we'd like to open up. Are there any questions so far from the audience? I do have one question for you, Dr. Gardner. It has to do with ALOX5. It seems like there are quite a few genes that are involved, and it may be something where, is it your impression that there may be no single gene to be, the one end-all be-all or the magic gene, if you will, but more likely an extent of contribution from several of these genes combined, if you will, in affecting the leukotriene pathway?
Correct. Upon evaluation of the literature, that seems to be the overriding consensus. And plus the fact there are more polymorphisms that are being uncovered in each of these genes. And of course, if you review the ALOX5 the leukotriene synthesis pathway, you can see there is a complex regulation within that, obviously supporting that statement.
Thank you. At this time, I don't see any questions on the chat function command, and I don't sense any questions being stated verbally. So once again, I'd like to say thank you to all the attendees, and absolutely thank you to Dr. Gardner for the presentation. If questions arise in the future, please contact us at pharmacogenomics@ucsd.edu or visit our website at pharmacogenomics.ucsd.edu. At this time, the session is ended. Thank you all for attending.
Thank you.
Thank you. Please stand by.